This program is brought to you by Emory University.
Well, good morning, everybody. Happy Friday. Welcome to another edition of Journal Club. Our presenters this morning are Dr. Terry Mclaughlin and Dr. Mariem Sawan. Terry's going to present his article first. Terry did his residency at the University of Pittsburgh and is headed next year to the University of Rochester. And he's going to present the CLEAR trial that came out just a couple weeks ago. So take it away, Terry.
Thanks, Dr. Williams. Thanks, everyone, for being here this morning. If you were at ACC and saw this a couple weeks ago, hopefully I don't bore you. So I'm going to be presenting the bempedoic acid and cardiovascular outcomes in statin-intolerant patients article that came out in the New England Journal. I think it came out last week after the ACC 2 weekends ago. And it's known as the CLEAR trial. Also, I sent out a couple of the editorials as well, one of which is, your typical editorial after a big article from the New England Journal. The other one is an editorial just describing how bempedoic acid works, if you want to look at any of the sources that I looked into. So what is bempedoic acid? I haven't thought about the pathophysiology of drugs at this level in a while. So it was a nice refresher for how statins work as well. But bempedoic acid is a medicine that lowers your LDL. It works on the same pathway as does statins. So the difference between the drugs comes by the fact that bempedoic acid is administered as an inactive drug. And rather than going to both liver cells and skeletal muscle cells, bempedoic acid only functions in the hepatocytes, and that's because it requires converting or an activating enzyme. And once it is activated in hepatocytes, it just works upstream of the HMG-CoA reductase where the statins work. It works on this ATP citrate lysase. Has the same effect downstream, though, by reducing intracellular cholesterol production. It upregulates LDL receptors, thus lowering LDL in the blood. We'll get to it later, but by virtue of the fact that bempedoic acid is inactive and does not function within the skeletal muscle cells, some of the outcomes we see, such as hyperglycemia and myopathy from statins, were proposed to not be a concern with bempedoic acid. Just another slide from that editorial highlighting the fact that it is a prodrug, and the way that it works is by getting the LDL receptors within the cell membrane to take in LDL from the blood. The brand name of bempedoic acid is Nexletol. It's a 180 milligram tablet. It has previously been studied not looking at outcomes per se, but looking at lab values such as LDL lowering effects. So this study expands upon previous studies insofar as it was looking at more clinical effectiveness, outcomes. So what they tried to do with the CLEAR outcome study was test both the efficacy and safety of bempedoic acid. And the population they used were patients with high risk for cardiovascular disease or who have cardiovascular disease and are statin intolerant. So the study inclusion-exclusion criteria, it took essentially people of all ages, 18 to 85, men and non-lactating women. Typical inclusion criteria or exclusion criteria you would expect for studies, stage 4 heart failure, cancer, substance use. They also excluded poorly controlled risks, A1C greater than 10 in diabetics, and uncontrolled blood pressure greater than 180/110. Recent cardiac events, poor renal function, poor liver function at baseline, elevated triglycerides at baseline. Those people were all screened out. And then they included people who had an LDL greater than 100, people who were on a low-dose statin or another lipid-lowering medication were allowed in the study, but their definition of statin-intolerant patients were individuals who have tried more than 2 statins before, at least one at a low dose, and were unable to tolerate it or unwilling to continue with it. And again, this was both high-risk primary prevention and secondary prevention patients. By the time they got through all that inclusion and exclusion, there was 6,900 patients essentially in each arm, and about 6,500 at the end were alive in each arm. Table 1, the characteristics of the patients. Sorry, it's not that big, purposefully full. So I'll just kind of highlight what I thought was important from it. In our secondary prevention groups, it was about half coronary disease. However, there was about 10% of patients who did have peripheral artery disease and about 15% who had cerebrovascular disease. Baseline labs were about an LDL of about 140 and an HDL of about 50 with elevated high sensitive CRPs. There's a distribution, bell curve distribution of patients less than 65 and those 65 to 75 and those greater than 75. Women to men were relatively half-half. They're about 48% female in both arms. And then the patients were on other lipid-lowering medications that we typically use, such as statins, and 23% of the time at a low dose. Zetia was used in these patients at about 11.5%. PCSK9s and niacin and all those other sort of agents were used at lower rates, so low that they did not include it in the table 1. It is in the supplementary information if you're looking for any hard numbers. And once they did have those cohorts of about 6,000 to 7,000 patients in each arm, they first, similar to previous trials, looked at the biomarker outcomes. And what they saw was bempedoic acid, as previously shown, did lower the cholesterol early on, at least to 21%. And the high sensitive CRP also was reduced by about 22%, 2019, about by the end of trial, throughout the trial. So by biomarkers, both inflammatory and lipid levels, we are seeing that bempedoic acid does lower the numbers as we have previously seen. The pre-specified outcomes they were looking into for their primary endpoint was a composite for major cardiovascular events, including non-fatal MI, non-fatal stroke, coronary revascularization, and cardiovascular death. They then set forth hierarchical, sequence testing of secondary outcomes, including a 3-component MACE, which removed cardiac revascularization, coronary revascularization, all types of MIs, revascularization on its own, all strokes, cardiovascular death, and mortality. Our table 2, or our clinical efficacy points, kind of gives us the numbers for each of these outcomes. And what you'll see is the significant findings come in the first 4 pre-specified outcomes, the primary endpoint and the first 3 secondary endpoints. Rather than going through the nitty-gritty of this table, we'll go through the next number of slides highlighting one by one what was seen. The primary outcome of this death from cardiovascular cause, non-fatal MI or stroke or coronary revascularization, was significantly lower in the bempedoic acid group versus placebo. It was 11.7% versus 13% with a hazard ratio of 0.87. So they did meet their primary endpoint. The secondary outcomes, first, the 3-component outcome, which was the same as the first, except they got rid of coronary revascularization. It was 8.2% in the bempedoic versus 9.5% for a hazard ratio of 0.85. All comers of myocardial infarction, both fatal and non-fatal, were less in the bempedoic acid group, 3.7% versus 4.8%, with a hazard ratio of 0.77. And coronary revascularization was lower in the bempedoic acid group, 6.2% versus 7.6%, with a hazard ratio of 0.81. The remainder of the pre-specified secondary outcomes were not significantly different when comparing bempedoic acid to placebo, and that includes fatal and non-fatal strokes, all-cause mortality, and cardiovascular death. When they did subgroup analyses, as with all research trials, you can take them for what they're worth, more hypothesis generating than anything, I think. But what I'd like to draw your attention to here is when you look at these plots for patients who had a BMI greater than 30, so down here, the second to last portion of the graph, you'll see that it was significantly, with a p-value of 0.06, in favor of using bempedoic acid. And also in a primary prevention subgroup, this last row down here with a p-value of 0.03, there is a signal that it favors the treatment of bempedoic acid relative to secondary prevention. The remainder of the subgroup analyses did not come out to be significantly significantly different, and that's looking at the biomarkers and the different lab values, plus the use of statins versus Zetia, et cetera. Turning our focus to the secondary point of the study, looking at the adverse effects of the drug. In some, the authors are saying that the adverse effects based on their data did not lead to significant drug discontinuation, with no difference in the placebo versus bempedoic acid arms. However, we should pay attention to the fact that there are a couple adverse effects that one may want to draw their attention to. There were elevation in your liver function enzymes in 4.5 versus 3% of folks who took the bempedoic acid versus the placebo. Renal events such as AKIs were higher, 11.5% versus 8.6%. Not surprisingly, myalgias were less, 5.6% versus 6.8%, as that makes sense as we went through the the method of action of the drug not functioning in the skeletal muscle cells versus the hepatocytes. And then kind of one of the problematic portions of this is patients who are in this sort of phenotype for high cholesterol, high risk for adverse cardiac events. They often are overweight and are at risk for gallstones and or gout. And what we found in this study was the bempedoic acid group had a higher rate of uricemia and higher rate of gout, 3.1% versus 2.1%. And additionally, the patients also had a higher risk for cholelithiasis, 2.2% versus 1.2%. So something to keep in mind for this type of patient population. All said, the authors concluded that in this RCT placebo-controlled trial, in patients for primary or secondary prevention who were unable or unwilling to take low doses of statins, treatment with bempedoic acid reduced the primary outcome of the 4 composite death from cardiovascular cause, non-fatal MI, non-fatal stroke, and coronary revascularization at a median follow-up of 40 months, or say 3.5 years. In the discussion, the authors point out, they did meet the efficacy outcomes in the primary and most of their secondary outcomes. They did show that the biomarkers were lower. There were few adverse effects. They did highlight what we talked about with these adverse effects. They did highlight that the myalgias were less of a concern than in the statin population, as with diabetes, because of the action within the hepatocyte rather than the skeletal muscle. They highlighted that compared to other lipid-lowering modality studies, they reached their primary endpoint by a similar amount than the PCSK9 and the ezetimibe trials, albeit the primary endpoints were slightly different. They highlight that in some of the statin trials, they did not lower those trials did not lower cardiovascular death, and it wasn't until they did meta-analyses that they showed there was a mortality benefit. They highlight that in the PCSK9 and Zetia trials, the inflammatory markers such as high sensitive CRP levels were not lowered, where in the bempedoic acid trial, we are seeing lower levels. And then they highlight that, there was a large portion of women that were in this trial, more than other lipid lowering trials. And finally, that they make note of the fact the subgroup primary prevention had a lower hazard ratio than did the secondary prevention group. Like I said, kind of more hypothesis generating rather than something to take to the bank necessarily. One of the limitations of this trial is, statin intolerant patients, although common, up to 10% of patients that take statins, we often are treating our patients with statins and looking for that secondary agent to add. And this trial, the biggest limitation is it did not look at that in combination with conventional standard doses for the outcomes. And perhaps that would be a good follow-up study to see, should we be reaching for bempedoic acid before we reach for, Zetia as we normally do. The editorial brought up 2 points I'd like to highlight. The primary prevention subgroup could have been chance alone, or is this the fact that, there's a temporal difference with the development of atherosclerosis where bempedoic acid could be more helpful early on? Who's to say? Not fully clear. And then again, as I stated before, although there's no mortality benefit, could that be because some of the patients were on other sorts of lipid lowering medicines at low rates, almost 25% for the statin, 10% for the Zetia. And again, other statin trials didn't reduce mortality until until they put them into meta-analyses. My takes, just kind of reiterating what we've said already between the author's conclusions and the editorial's comments. But what I'd like to say is that I don't think this is hugely practice changing for me. However, it's not going to affect every patient that walks in the door. However, there is going to be a niche of patients who fall into this category that could benefit from bempedoic acid. And in fact, I'm on prevention this month, and I had a patient just yesterday come in and she said, "Hey, I saw a new lipid lowering drug in the newspaper. What are your thoughts on that? Should I be on that?" So, this made it out after ACC in the past couple of weeks into the lay media, and patients are already coming in and asking about it. So it is a good medicine to learn about, because like I said, there is going to be that subpopulation of patients that will require this medication. One thing I do want to, tie in with this study too, that I thought was interesting was, this was a global study in a number of different countries, and, things happen. And as we saw with COVID, a lot of trials got truncated a couple of years ago, but here's a real world consideration for these multinational trials. This is a quote from the New England Journal article. Data on key efficacy endpoints at trial sites in Ukraine were censored after the start of the conflict in 2022. I also think it's interesting that the editors allowed this in the journal without calling it a war per se, but nevertheless, not to get political. Here is kind of everything I talked about. It's the virtual abstract from ACC, and I just wanted to take some time now to allow for discussion, questions, or anything to that extent. Thank you.
Thank you, Terry. Good review, good article. Yeah, I guess you're right. I mean, it seems like it's sort of on ezetimibe's corner here. Right. I mean, you sort of referred to it a couple times that this is, maybe a new option for plan B for statin intolerant patients, either for primary or secondary. You're right. Not as much data in terms of as add-on therapy, but where, I was just looking it up while you're talking. It's roughly a third the price of ezetimibe, which I think is one advantage that it might have as well.
Oh, I appreciate you looking that up. I meant to. I didn't get around to looking at that price. I knew it was. It's quoted as being cheaper than PCSK9s, which is good.
Everything is, I think.
It's good to hear it's cheaper than ezetimibe too. One interesting thing I found out about this, working with Dr. Wilson at the VA last week, was the same, I want to say the same pharmacist who created Lipitor now created bempedoic acid. So good for him. I think this one will be reasonably affordable for patients, and within time maybe be something that we're reaching to more commonly. But for now, I think it just fits in that niche of statin intolerant patients.
Other
Terence.
comments, questions?
Stan Sherman. Doesn't this come as a combo with Zetia? Don't they make this? And did they use that? And did they use that in the study at all?
Yes, sir. There is both a combination. It's the brand name is Nexletol for the bempedoic acid one. I didn't write it down. There's a similar name, but there is a combination: 180 milligram bempedoic acid and 10 milligram ezetimibe combination drug from the same company that was studied in some of those it was either like Clear Harmony or one of those previous trials, and they did not specify if they used that specifically in this trial. I think that it was probably individual drugs, because the patients would have been blinded to whether or not they were receiving the bempedoic acid. So it was either placebo or the study drug, and then about 10% of the patients were on individual ezetimibe pills.
Nexlizet.
Nexlizet, yeah. I think the combo would probably save some money with these drugs and be more effective than the bempedoic acid itself.
Other questions, comments from the group?
Hey, this is Neil Dickert. I just would add one thing. Really nice presentation. One of the things that's always important is to think about the time of follow-up and sort of what's a reasonable, what kinds of effects you're expecting to see. This is a drug that I guess the average follow-up was like 40 months or so, but it's a drug that people are going to be on for many years. So when we look at what seem like relatively small absolute differences, it's always important to think about the kind of lifespan over which people are going to take the drug, and then the impacts seem certainly more significant, and it's just always good to contextualize that in terms of how long people are actually likely to have a chance to have the effect of the drug.
Dr. Dickert, thank you for making that comment. The authors do discuss that at the end of the paper as well, that perhaps with a longer follow-up, maybe there would be more of a mortality or cardiovascular death benefit. It is tough to say in 3.5 years on a medication like this, especially when it was a 30% primary prevention population. So
Right.
Absolutely, that's a very good point. Thank you, sir.
Yeah, if you look, it's hard. You got to be careful extrapolating into the future, but the curves don't even really separate for a year. And then they seem to be, it's not one of those where it separates right away and then at two parallel lines. They seem to be growing apart as time goes on, which would maybe speak to the long-term potential improved outcomes of this drug. Our next speaker is Dr. Mariem Sawan. She is also a graduating fellow, did her residency at the University of Maryland. She will be staying on as an interventional cardiology fellow next year, and she's going to talk about another recent trial that was in Lancet here in the past couple of weeks, the BIOVASC trial. Take it away, Mariem.
Thank you. Good morning, everyone. Today, as mentioned, I'll be presenting the BIOVASC trial, which was also presented at this year's ACC conference. The trial studied immediate versus staged complete revascularization in patients presenting with acute coronary syndrome and multivessel disease. The name BIOVASC comes from the type of stent that they used in the trial. So all patients received a bioresorbable polymer sirolimus eluting stent to try to reduce bias. I have no financial disclosures. So the rationale behind conducting the trial was that prior studies found that patients with STEMI had less ST segment resolution upon revascularization and a worse prognosis when they had multivessel disease compared with single vessel disease. And the recently published complete trial, which was published in the New England Journal of Medicine in 2019. I guess it's not that recent, but it demonstrated a primary combined endpoint of cardiac death or repeat myocardial infarction in patients undergoing staged complete revascularization compared to culprit-only revascularization approach. And the complete revascularization didn't take place during the index procedure and was rather within the 25 days of the index procedure. So prior studies really didn't focus on the timing of the complete revascularization, and that's why this trial was created. In regards to trial design, the BIOVASC trial was a multi-center prospective randomized non-inferiority trial. Patients who presented with ACS, who underwent left heart caths that was evident for multi-vessel disease and a clearly identifiable culprit lesions were enrolled. So patients were enrolled after the left heart cath, but before the start of the PCI. And the definition used for multi-vessel disease was 2 or more coronary arteries that were 2.5 millimeters in diameter or more, and at least 70% stenosis by visual estimation or positive coronary physiology testing. They then randomized these patients with a ratio of 1:1 to either an immediate complete revascularization of all lesions deemed significant at the time of index procedure, or to a staged complete revascularization group where only the culprit lesion was revascularized at the time of the index procedure, and the other significant lesions were treated within 6 weeks of the index procedure. The inclusion criteria included patients between the ages of 18 to 85 and patients who presented with ACS and had multi-vessel disease with a clearly identifiable culprit lesion. The exclusion criteria included previous coronary artery bypass surgery, cardiogenic shock, the presence of a CTO, and the absence of a clear culprit lesion. So also in the trial design, so they were randomized in a 1:1 fashion. It was a multi-center trial that took place in 29 different hospitals across 4 different countries, which were Belgium, Italy, Netherlands, and Spain. The protocol was designed by the Academic Steering Committee. It's funded by the hospital in Netherlands, Erasmus Medical Center, and the university collected and held all trial data. Biotronic, which is a stent company, basically provided an unrestricted research grant to the university hospital to support the trial, but it wasn't involved in the trial design and had no role in the collection, analysis, interpretation of data, or in preparation. As I mentioned, a bioresorbable polymer, sirolimus-eluting stents were used in all patients to reduce bias. And then a few definitions. So the definition they used for culprit lesion identification, so at least 2 of the following morphological features had to be present to call it a culprit lesion, which is intraluminal filling defect consistent with a thrombus, plaque ulceration, plaque irregularity, dissection, or impaired flow. And then for complete revascularization, it was defined as successful PCI of all clinically significant lesions in vessels with a diameter of 2.5 millimeter or more and final TIMI grade 3 flow. So not to go into the finite detail, but before moving forward, I did want to point out that follow-up was complete for 753 patients in the immediate group and 753 patients in the stage complete group. And in the immediate group, immediate revascularization group, there were 16 patients that did not receive the allocated revascularization during the index procedure, primarily because of either prolonged procedure time, procedure complexity, or excessive contrast dye use. There's 10 patients that crossed over to the stage group, 11 patients without complete follow-up. And then there in the stage group, 35 did not receive their allocated intervention for various reasons as well, and 8 without complete follow-up, either because they were lost for follow-up or because they withdrew their consent. So the primary outcome was a composite of all-cause mortality, MI, unplanned ischemia-driven revascularization at 1 year from the index procedure, And the secondary outcome was all-cause mortality, MI, and unplanned ischemia-driven revascularization, target lesion revascularization, and significant bleeding at 30 days and 1 year after the index procedure. Unplanned ischemia-driven revascularization was defined as revascularization performed after the index procedure, and in the case of in the patients with the stage group, before the planned date of stage intervention that was prompted by either dynamic EKG changes, new rise in cardiac enzymes, or both. So here's the baseline characteristics, and there was no significant difference in the age between the two groups. The mean age was 65 in both. The majority of patients were men in both arms. There was no significant difference in the number of patients and the type of ACS, whether it was STEMI and STEMI. There's a slight difference in unstable angina. There's also a slight difference in patients with prior MI or prior PCI, but there's no significant difference in the rate of peripheral vascular disease, renal insufficiency, or diabetes. They also tabulated presence of valve disease, COPD, history of stroke, hypertension, hyperlipidemia, and smoking that I haven't included in the table shown here, but there was no significant difference between those characteristics as well between the two arms. When it comes to the procedural characteristics, more than 95% of the patients in both groups underwent PCI using a radial approach. The location of the culprit lesion, whether it's the left main, LAD, CIRC, or RCA, was not significantly different between the two groups. The majority of patients had one non-culprit lesion. And there was no difference in the type of lesion, whether it's type A, B, or C. The majority of patients had, there was a very significant difference in the physiological testing and the use of intracoronary imaging. So if you look here, the use of FFR and IVUS or OCT was very little. And, you know, really this is somewhat understandable in the setting of STEMI, especially, but given that little over 50% of patients who presented actually had NSTEMI, this really reflects poorly on the current practice in these countries. There was also a significant difference in the length of hospital stay between the two groups. They also looked into the duration of the procedure. And as you can imagine, the duration of the index procedure in the immediate revascularization group was much longer than in the stage group. However, when you add the duration of the index procedure and the staged procedure, you find that actually the patients that underwent a staged procedure had a longer duration, total duration. And looking at the amount of contrast that you use, the same scenario repeats itself. So in the immediate group, during the index procedure, obviously they used more contrast, and you can, that's anyone could guess that because you're treating more than one lesion at that same procedure. But in the stage group, in the index procedure, they use less. But overall, if you add both procedures, the stage group actually received the total contrast that's significantly higher. And the same thing is when you look at the total area dose of radiation between the two groups. The investigators left the use of antithrombotic therapy up to the discretion of the operators, but there wasn't a difference between the two groups, and all patients were on DAPT for 1 year, and there was no difference between the two groups when it comes to the use of DAPT either. At 1 year follow-up, the primary composite outcome occurred in 7.6% of patients in the immediate complete revascularization group, and in 71 patients in the staged complete revascularization group, with the p-value of 0.001 was obtained from a test of non-inferiority. But they do mention that when a superiority is tested, the p-value was insignificant. It was equal to 0.16. When it comes to secondary outcomes at 1 year after the index procedure, myocardial infarction occurred in 1.9 of patients in the immediate group, and 4.5 in the patients with stage revascularization group. The p-value that is also significant. This was really mainly driven by early events, and the median time to repeat myocardial infarction was significantly different. In the immediate group, it was 235 days compared with 16 days in the patients with the stage group. Also, at 1 year after the index procedure, the unplanned ischemia-driven revascularization was performed in 4.2% in the immediate group, compared to 6.7 in the staged group. And the occurrence of major bleeding was not significantly different between the two groups. So this is the Kaplan-Meier curve that showed the same, which is the first curve at the top. At 1 year follow-up, the primary composite outcome occurred in 57% of patients in the immediate group and in 71% in the stage group, with a hazard ratio of 0.78 and a p-value of 0.001. And the curve below it shows that at 1 year after the index procedure, myocardial infarction occurred in 1.9% of patients in the immediate group and 4.5% in the patients with staged revascularization, with a hazard ratio of 0.4 and a p-value of 0.0045. They also performed a pre-specified subgroup analysis. In this sub-analysis, it didn't identify significant interactions for the effect of immediate or stage complete revascularization on the primary outcome, so none of the p-values are significant. And so lastly, the trial limitations, really coronary lesions were mostly treated on the basis of angiographic severity, which was assessed mainly by visual estimation. The identification of culprit lesions might be misleading when you visually estimate it, and that's something that we all are aware of. And it was only used, especially in the setting of STEMI and staged revascularization group. And so the thought here was, there's also some concern that some of the culprit lesions might have been mistakenly missed or falsely identified, because they mainly used visual estimation instead of intracoronary imaging or physiology. And they also mentioned another thought that some of the non-culprit lesions might have had some features, like unstable features, at the time of the index procedure, but because they weren't revascularized, they were missed. And that's why that accounts for the higher incidence of repeat MI in patients with stage revascularization. But really, to me, that just emphasizes the need that you should use intravascular imaging during a procedure, because you're less likely to mistakenly identify a non-culprit lesion as a culprit lesion, and B, you're less likely to overlook any unstable features in the non-culprit lesion that would sway you one way or another to actually treat that lesion during the index procedure itself. And then the other thing that would introduce bias is that they did include patients with STEMI and unstable angina, and we know that the timing of PCI and treatment prior to PCI differs in these patient populations. So in conclusion, the investigators found that in patients presenting with acute coronary syndrome and multivessel disease, immediate complete revascularization was non-inferior to stage complete revascularization for primary composite outcome, and was associated with a reduction in myocardial infarction and unplanned ischemia-driven revascularization. Thank you.
Okay, thank you, Mariem. Very good review. Yeah, I mean, I don't know. I think I want to just sit back and see what other folks have to say. I don't want to jump in verse on this one. I want to defer and let some other folks have some comments. I may chime back in a little bit later, but comments, questions from the group regarding this study. I guess one question, Dr. Diggert, if you're still there. if you have any comments about the, these one thing that interests me about these studies is the sort of logistics and of in the midst of an acute MI is consenting, enrolling, randomizing a patient sort of in the setting of an acute MI, and sort of how that potentially works. If you're here, I don't know if you have any comments on, not to put you on the spot.
Sure. Yeah, and I apologize. I'm in the unit right now, and I had to take a phone call, so I missed some of the more substantive parts of the study itself. But with regard to that process, that's something we've done a lot of work on. And I guess, as you say, it's always hard to know how best to engage with people in an acute event about, you're having a heart attack, you need to go to the cath lab, and by the way, would you like to be in a randomized controlled trial? That's not exactly what people are expecting. It's interesting what we've found, and we've done a fair amount of research on this. There are some people that say, it's a problem to even try to get consent from people. What we've found is, I guess I would summarize as, in general, people's understanding is what we would expect. It's not very good in those contexts, but it's also the case that they generally appreciate being asked and are not that worried about the fact that they don't understand what they're signing up for. So the sort of take home point for at least for our work and how we've been trying to direct this process is that we should focus on making things as short and simple as they can possibly be, with the notion that the goal is probably not the same kind of protective function that consent might serve in other contexts, but rather just to show respect for people by giving them a chance to say no. So as I think about kind of enrollment in the acute context, the real goal of that process is if people really don't want to be a part of a research study, that they have the chance to say no. But it's probably not going to be a very substantive decision in terms of what that means. So we can't expect something that we might expect in other contexts. The other thing is obviously the study matters, right? So when you're looking at just an issue of stent types versus, something like, do you get mechanical circulatory support or not in the context of, cardiogenic shock, right? Those are very different kinds of studies in terms of what's at stake for people. So all those things I think matter a lot. But the goal really is, I think, to try to at least be transparent with people and give them an opportunity to say no and not expect more out of the consent process than is realistic in the context of the acute event. I don't know if that addresses your question, but
it does. And I guess the other thing, go ahead.
I was just going to say, there are regulations that allow you to do research without consent when you're in situations where people truly can't, they're unconscious, or the time limits are so significant that they can't possibly be engaged. In general, acute MI is not a situation where that tends to be the case, because for the most part, the patients you're interacting with are at least conscious.
Stan Sherman again. I just don't think in the midst of these acute settings that, they got in the whole team, that it was a discussion and saying, this really doesn't matter whether we do this now or later, or, did the angioplasty team say, there are really some lesions we can just easily do later, or I just not clear to me that the study just said we're going to complete revascular surgically or we're not.
And Mariem, I was going to ask you your thoughts on the non-inferiority aspect of this trial. Do you think that is the way they just sort of had to do a trial like this, or do you think, why they didn't try to, design it to demonstrate superiority of the revascularization? Because it seems like they almost got to that point, but see if you have any thoughts on that.
So they decided to do a non-inferiority trial from the get-go. They actually published the rationale behind the trial design. I think they from data that they collected from prior studies or saw from prior studies, especially from complete, I think they knew that it wouldn't come up as a superiority trial. And they actually did mention that when they did analyze the primary endpoint data, found that there's not superiority between the two groups. For me, the big take home message is that I don't think the take-home message is that you need to use intracoronary imaging more often. I mean, the lack of use in intracoronary imaging was huge. And the two things that they emphasize is that there was higher repeat MI in patients that were staged, and there was higher unplanned ischemia-driven revascularization in patients that were staged. Well, you can avoid both, and they were saying that most likely is because when you don't treat all the lesions, significant lesions in the index procedure, you're most likely to have ischemia-driven revascularization that's unplanned later. But if you use intracoronary imaging, then you would avoid that. You'd avoid missing the culprit lesion during the index procedure, and you'll also be able to identify other lesions that might not be the culprit, but at that time during the index procedure have features that make them unstable, that then you would treat during the index procedure. So if this trial was done the same way and they used 70-80% of intracoronary imaging or physiology, and they found the same results, I think that would change how I would look at it. But since they didn't, and it was abysmal how much they used any imaging or physiology, I think this trial didn't really change how I would approach it. I would still use intracoronary imaging, and Emory always uses like more than 80-90% of cases. Intracoronary imaging are used before and after stent deployment.
And I certainly it does answer the question, for you, a future interventionalist, in this setting, assuming patient stable and renal function and everything else, that, right, it does answer the question, like, should I go ahead and fix this, these other lesions? And the answer seems to be from this study that, yeah, it's okay to do that if the situation allows.
Yeah, of course. Yeah. We always keep the amount of contrast we're using and the radiation that the patient is exposed to in mind. That definitely, yeah, is something that everyone considers. Good point. I guess it's hard, like, especially it's in the middle of the night,
Yeah.
I can understand why some places, or even, at our location, if, you're hammered with a lot of STEMIs in different locations, that you might not always use the intracoronary imaging or physiology, but at least you try to. Especially that 50% of the patients in this trial was end STEMI. So it's not like in the middle of the night STEMI patients.
So I just guess it gives you permission to go ahead and do everything. It's a permission study.
It's a permission study. It's not at all exciting as a new drug, that's for sure. Another PCI study with some finite detail, I guess, so that you're not, yeah.
The other just interesting point a little bit is it did reduce incidence of myocardial infarction, which, a lot of PCI studies have not shown that, like you would expect, reduction in ischemia-driven revascularization or revascularization in general, but the actual reduction in acute coronary events is, that was, to me, a little bit interesting, in that it's something that traditionally, when we talk about this stuff, it's like, well, what PCI does and doesn't do. Now it's sort of like, well, maybe, it sort of changes your thinking potentially a little bit, particularly in this specific scenario.
Yeah, that's true. That's a good point.
All right. Any other questions, comments from the group?
I would just add, Robbie, the one thing I would say with regard to your last comment about the MI result, and again, I apologize for having sort of missed a little bit of the description of this. when you look at that picture, it's all immediate, right? So all of that reduction in MI happens within the first 1 to 2 months. And so that's a bit of a strange finding, right? That when we think about people that we take that come in with acute MIs, the number of people that have a recurrent MI within the first 30 to 60 days is not that high. So it sort of makes you wonder. It gets a little bit to Miriam's point about the lack of sort of complete characterization of what's happening with these lesions. That seems odd to me.
Yeah, I agree.
I mean, it immediately diverges.
All right. Well, thanks again to our presenters, Terry and Mariem. Fantastic job. A couple interesting trials and good things to think about. And thanks for everyone for tuning in. Have a fantastic Friday, and we'll see everybody next week.
The preceding program is copyrighted by Emory University.